everyone. Welcome to Two Doulas and a Midwife. We're back again. Very exciting because last week we ended off with the baby actually crowning, and we had to end our podcast because time ran out. So we're going to carry on now with that baby coming out in a beautiful natural birth, and we're going to go from there and see what they do with baby and how you're going to be feeling. Do you need stitches or not, and what that procedure is. So I'm going to hand you over to Danielle to introduce herself and then on to Sharon, and we'll get straight into it and birth that baby. Danielle.
Thanks so much, Lisa. Yeah, we left last week on a bit of a cliffhanger. Said it feels like we've been crowning for a week. We've reached that exciting, amazing moment where your baby's head is literally almost coming into the world. And I remember my midwives at the point of my baby's crowning told me to reach down and touch your baby. And, you know, I just did it, initially, there's no time to think. And sometimes you think, oh, no, I don't want to. But I just did. And it gave me that incredible, wow, my baby is almost here. 2 minutes ago, I said, I can't do this anymore. And just feeling that baby's head right there just gave me that extra bit of oomph to push that baby out. So, Sharon, you can tell us all about that moment and what you do as a midwife once baby reaches that point. So, very exciting in the birthing process.
Well, I'm so glad that you said that, what I do as a midwife, because of course all practitioners work differently. Doctors work differently to doctors, and midwives work differently to midwives and to doctors. And so, of course, I can only say what I do, because there's a variety of things that might happen. So because my focus in the pregnancy is all about getting to the mum to be the healthiest version of herself that she can possibly achieve, then I have a standard of a hemoglobin which needs to be over 12 so that I'm not expecting her to have a postpartum hemorrhage, and that she's just going to be in the kind of health that it was created for giving birth. So we've been doing all her checklists along the way and making sure that all her blood picture is good and healthy and that she is in fine fettle. And so this head was coming. And if she is on dry land, then my mums are what I call it in a tripod position, which means that she's on her hands and knees, but she has her right leg bent. And so her hand and her foot are in close proximity, and her elbow and her knee are close to each other. So she's braced in that position. So she's got her right hand then free to have on her baby's head, so that she and I are working together to get that baby over the perineum. Now, of course, we do perineal massage from 28 weeks. And so, again, the perineum is elastic, is stretchy. And if she's on dry land, then I am applying hot cloths to her perineum. And I use geranium and lavender because those also help to ease skin and tissue. And I use a homeopathic remedy called cuprum, uh, which is I smear on as an ointment, which again allows the muscle to relax that little bit more. And just before crowning, we are having the conversation, which is not easy for her. We have discussed it though beforehand in the classes, that I will want her to do a little push and then just breathe, and a little push and breathe, and then a big push maybe and breathe, so that we are using the power of the contraction to ease the head over the perineum. This way I've got a very high intact perineal rate, and very few of my mums ever need stitches. And so she's easing that head out of her body. If she's in the water, then the water, of course, is making the perineum more supple and elastic. And I can still use the cuprum on her perineum, but of course we don't have the need for hot cloths or other things. We can't use aromatherapy in the water. And so as the head is just crowning is when the widest part of the head, these bony bits, the wooden bits here, come over the perineum. And if she can just blow that bit from here, this is little push, just breathe, little push, just breathe, and then and just allow that head to slide over the perineum, and then the face is revealed. So if she's upside down then on her hands and knees, it is the face that we see. When a woman is on her back in hospital, then it's the back of the head that everybody sees, and you don't see the face. So we see it the other way around. And then we wait. If she's on dry land and she's on her hands and knees, and we're waiting for the next contraction with the head presenting as in out, and we're waiting for the next contraction, which might be 3 minutes away because the contractions spread out in the second stage. And she's looking, we've got a mirror, and she's looking down and she's seeing her baby's face, and we're waiting. I'm checking that there's no cord around the neck. And then it's time as the body gets pushed down against the pelvic floor with the next contraction. So the shoulders then restitute, and that means that the baby rolls so that you've got one shoulder on top of the other, and they're not coming out sideways like a rugby player. So when the baby restitutes, then that's the time for her to give a big push for the shoulders, and I pass the baby directly to her tummy. She'll then sit down on her heels and take her baby in her arms. And that's when she gets the highest level of oxytocin she'll ever have in her life. As she inhales her baby, smells her baby, better than a new dolly. You know, if you remember the smell of a new dolly, it's just lovely. But a baby smells even better than that. And so she'll inhale her baby. She sees her baby's face for the first time. And that's when she has the highest level of oxytocin, her love hormone, that she will ever have in her life. And that's in the hour after the birth. And that's why we can birth the placenta as a physiological third stage, because with that enormous high level of oxytocin, it's making her uterus contract very strongly in order to release the placenta. And so she's sitting on the floor, first of all, or she's still in the pool with her baby, enjoying her baby. And then she's going to climb out of the water if she's been in the pool and sit on my very luxurious bucket, or she's going to get up off the floor and sit on my very luxurious bucket. And then we put a big towel or a blanket around her shoulders, and then she's like a cormorant, how she's sitting perched on a very comfortable camping stool, in case you think you're perching on a bucket, where she can sit comfortably in a squatting position for as long as she needs to in order to release her placenta. So she's warm and cozy. We've had her blanket on the heater, and while she was in the second stage, she got a nice warm something around her shoulders, not a little towel that you get in a hospital, like it just comes up to the end of your rib cage, but a nice big something that she has brought from home. I always imagine an American Indian, you know, sort of a Pocahontas idea with her culturally enriched blanket around her shoulders. And so then we're waiting for the next contraction. And at the same time, the cord continues to pulsate. And it is my promise to myself and to my mums that I sit on my hands for that 10 minutes. So we're checking that the cord is pulsating, the baby's getting oxygen still from the placenta then, and nutrients from the placenta as the cord continues to pulsate. And that's why we ask for delayed cord clamping. If you're doing the hospital thing, that delay can be a variety from 30 seconds to 3 minutes. But in actual fact, it takes on average 10 minutes for the placenta to continue to do its thing and then to pack up. And that means that the difference is that if we rush to clamp and cut the cord, the baby has to breathe and has to be in charge of breathing. In a physiological third stage, then we wait until the baby has the benefit of the placental respiration and learns to use their lungs at the same time. So it's more gentle and careful, and the baby gets all the stem cells then that are designed for that child and created for the baby, and of course gets the blood volume that they are entitled to from that placenta. And this is why we encourage, why mums ask for delayed cord clamping, but they don't really understand what it is. So in a physiological third stage, it means that the cord packs up first, and it goes from a pulsating, rigid, turgid, bouncy, springy, pulsating cord to a limp ribbon that is white and no longer communicating from the placenta to the baby. And the mum then will have a contraction, and she'll be able to tell me, I'm having a contraction or contraction coming. I'll check her uterus. Yes, contraction coming. So I will check to see where is the placenta. And if it's just there, dunk, 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 then I just ask her to push it out, and she'll push it out into my hand, and I will rotate it until the membranes coil behind it like a rope. So because we're trying very hard not to leave anything behind, because that can be bad for mothers. And then she just pushes it into my hands like that, and then the placenta isn't needed by the baby anymore because there it is in my hands. There is no further communication between the placenta and the baby because it's out of the mother's body. And then we clamp and cut the cord. And so doing it that way, we know that there was nothing left that the baby didn't get because it had already stopped transporting any good information from the placenta to the baby. And in that time, then the baby has strong respiration going. And of course, if we were looking at naturally resuscitating a baby, if a baby had had a traumatic birth, then we're still getting the benefit of the oxygen coming through the placenta in that case to the baby. And it is a form of resuscitation, even. So having the baby on the mother's chest, skin to skin, having the baby's ear against the mother's heartbeat, which is their familiar harbor, and the two of them smelling each other is going to stimulate the bonding for the breastfeeding. And drying the baby off with a warm towel, drying the mother's tummy off with a warm towel, and then enrobing them so the baby is covered with another dry, warm towel on the mother's dry body. Then they can get back into the pool then. And normally it would be the three of them together, the mum, the dad, the baby, all get into the pool again to have their first family ritual. And so I encourage them to write their vows, their letter of intention. What do I promise to you as your mother? What do I promise to you as your father? And they have their first family ritual. So rituals are very important to all human people, and we follow all sorts of family rituals, but that is going to be their first commemoration of being a family. And it's that time that the world stops around the family. The time is just held So I leave the room while they're doing that. I'm not involved in that. They do their own thing. Maybe they've got a piece of music that's playing. Maybe they've got a song, or they've written a poem, or whatever they've done to welcome their baby into their family. And then after that, when they'll give me a shout when they're ready to get out, and I come in, we get them out of the water into warm towels, and then we get the baby to the breast, and that's the rest of their lives started from that moment on.
Beautiful. Absolutely beautiful. It's so, like you say, the rituals are so rich and important, and you remember your birthday forever. Whatever, however your baby was born, you remember every smell, every moment, and I think your vows that you ask them to write is just so sacred and beautiful. But that's you, and I love the way you birth. But now, in a in a hospital situation, should someone be with a obstetrician? How would that look? Because I know it's very different. There's
Well,
bright lights. There's.
it's been a very long time since I saw that kind of birth. And if you consider then, why do midwives go out into independent practice? And it's because they have worked in hospitals and they see what is lacking, and they see how women are generally treated, and they know that a better care can be offered. And so you can imagine that midwives can be very frustrated in a hospital environment because it's all about numbers and speed rather than ritual and specialness. And so,
if I can, what I've
jumping,
got
go ahead, jump.
is what's so beautiful about how you described the whole labor process and pushing the baby, and that there can be a lull for 3 minutes between contractions as things slow down and baby's head comes out. Just it can, it's and you're talking about the speed of the hospital. And I've seen so many situations where a birth that was unfolding relatively naturally and in the way nature intended suddenly became emergent because the doctor's nowhere to be seen, or the doctor needs to come from home, or the doctor's busy seeing patients. And what's so wonderful with with birthing with an independent midwife is that your midwife is there with you throughout your entire labor and birth process. And there's no like rushing from the labor room into the delivery room, and there's no calling the doctor. The doctor has to catch the baby, and it's really it doesn't have to be an emergent thing to get the baby out. I've seen incredible videos of moms birthing in a birthing pool where their baby's head is out and is under the water and is and she's waiting for that next contraction, and there's no one rushing. There's no one oh, got to get this baby out, and we've got to, clamp the cord, and we've got to check that the baby's okay. That, when the process is allowed to happen naturally, then there is no cause for alarm and red flags and, bells ringing. And as Sharon
I
said,
think though, I think that comes though from fragmenting care. And that really is why midwives want to leave hospitals, because you're either working in the antenatal clinic, or you're working on the labor ward, or you're working in the postnatal care ward, and you don't get to see people. You get to see a part of a process. And when we treat labor like that, then of course, if you're just jumping in because this woman's in second stage and you have never met her. An independent midwife is, of course, seeing that woman not only through labor, but she's seeing her all the way through that pregnancy. And sometimes she's seeing her from before she's even pregnant to help her find the way in order to get pregnant. So she's seen her and she knows her, and she's taken her through her antenatal classes as well to prepare her for, like, I prepare my mums for my philosophy. This is what I am going to do. This is, I'm not going to break your waters. I'm not going to induce you. I'm not going to augment you. I don't want to do an episiotomy. This is how we avoid those things. And so this is what I expect of you. I expect you to learn to squat, and I expect you to do your squatting positions. I expect you to practice them. I expect you to do perineal massage. I expect you to eat well. I expect you to clean out your diet and clean it up. And I expect you to do a raw diet. And I expect you to journal and to do your mind mapping and come to class and come to your appointments and feel strong and feel ready and be in your healthiest state. I don't expect you to be anemic. I carry the drugs with me, obviously. I'm not going to let you bleed all over the place. But if you have a good hemoglobin and we have family planning where we've got gaps between babies and we're not like our grandmothers who had a new baby every year for 10 years, then we are fit and strong and healthy, and we're not designed to bleed all over the place. We are, in fact, designed to keep our blood in our bodies when it's healthy and working well. And so I find that midwives, of course, can be very frustrated working in the medical model of maternity and of obstetrics. And many of them feel like they're just an obstetric nurse, where, like you have just described, Danielle, they are not there to help the mother birth her baby. But when it just gets exciting and thrilling, that's when she needs to call somebody else who's going to step in. But the somebody else then has not had the history of that baby's fetal heart. Didn't see the baby in the first stage room of labor. Now she's in the second stage room. So you might have had a quick look at the CTG to see that this is a healthy baby that you are expecting, or that this is a baby who's not so healthy and is going to need to be birthed more quickly than you would like because they're not managing, and will need to have help from an oxygen point of view, or might need to be resuscitated. And of course, then you're going to manage it entirely differently. But if you have walked along with that woman and you have been at her side for 8 hours of labor or whatever it might have been, and you've been listening into that fetal heart every 15 minutes, then you know how the baby's managing the contractions, and you know how the baby's managing between contractions, and you know the sort of health of that child that you're going to expect as she is pushing that baby out. And so if this is a totally healthy baby and you're listening in the second stage, she pushes, you listen. She pushes, you listen. So you're listening to how the baby's recovering after that push. So again, then you know, how long can we wait? Can we wait with the head out? Or does she need to push faster in order that we can get hold of that child more quickly and give them a rub up or give them help? But those babies, and you're listening all the time, it's a good fetal heart, even in the second stage, with no dips and no concern, then we can wait. And you can even, you've got your hand on that cord as soon as it presents. So you know what it's pulsating at. Therefore, you know what the baby's heart rate is as soon as they're partially in, partially out, then you know the person that you are dealing with and what sort of time we have available. But if you consider why a midwife goes into private practice, then it's generally so that she can be there for all aspects of pregnancy and birth and the recovery after the birth, that she's helping that woman not only to gain the best health that she can in her pregnancy, to have the most beautiful, gentle birth, but also to breastfeed successfully and to recover mind, soul, and body after the birth so that she can be a happy family. And part of that, um, from my point of view, is beating men into submission so that they can be aware of their most important role in the world today. It staggers me that women have been fighting for equality and the right to equal pay and equal rights and, go and be the lawyer and be the astronaut and be whatever you want to be. Of course, it is still only she who can be pregnant and only she who can birth the babies. And if it is she who is the breadwinner as well, then, that's quite a load to carry. And he then, in the modern world, becomes very confused as to, so who am I then? And it's time that men realize that who they are, I hope, is a partner in a family unit, that his input is so important. The psychologists tell us that the problem with the world today is the absent father. And what I tell my dads is that you can be totally present in the house and totally absent at the same time. Or you can live in Sweden and have dinner with your children every night and have story time and have deep, meaningful conversations and be a totally wonderful dad. But unless you're going to give it thought beforehand, you're just going to fall into the one and only role model that you had, who is very often not the best role model that you have wanted to have. So my dads have to do just as much journaling and just as much mind mapping and question asking. And they have to realize that if that baby, how often do you think you're going to have to feed a baby when they're brand new? And when they come to the conclusion that, oh, duh, sometimes that's every 2.5 hours, that's day and night and day, and so it's my dads who are latching that baby. I show the dad how to latch the baby because the mother is recovering from being pregnant for 9 months. She's not recovering from 6 hours of labor. That's him. But then we'll peel him off the floor and give him a cup of tea and help him to recover, and then he's on the job because she needs to be looked after. Now, if she's looked after, she's able to look after the baby, and that makes them a unit. So I show him how to latch the baby, and then he feels great because he's oiling the baby, he's sunning the baby, he's got his hands literally on that baby, and he's giving me a report every day as to how many pees, how many poos, has the child upchucked, is there any blood in the nappy, he's doing the cord care. And so he knows that baby right from the start. He is bonding from that moment, and that's making them a very strong unit. So the fact, even if we look at the role of a dad in the labor, so many dads are told to just dress up in a silly outfit. He's only there for a couple of hours, but he's got nothing to do. And if we are looking at his his experience of her, she has a whole life's journey in a couple of hours. She will face fear and she will face doubt and she will face exhaustion and she will want to run away and she will face her darkest moment in her labor. And if he is witness to that and realizes her courage and her strength and her endurance and how she was able to, at the end of his exhausted 6 hours, still get it together and push that baby out, then I think that it enriches their relationship and brings them closer together and makes them something different that they have never been before that child arrived. Children can very often divide a couple, and it's very, very common. And that's very sad and it's the beginning of the end for a couple having children, but it can
You know,
also
so,
enrich a relationship.
sorry,
What were you saying?
I love that. And the role of the partner is so very important in the labor process. And I know as doulas, we encourage the dads to do all the massaging and the walking and everything. We just there to get that oxytocin going because dads very often don't know what to do in that situation. And so, but I want to come back to that labor room. And so now you've done this wonderful process and then got them back in the pool and all the rest. But now going to a hospital setting. So now I've done the birth unit birth, the hospital birth, government birth. You know, we've seen it all, and definitely the home birth and birthing unit birth are far more relaxed and better outcomes and happier eaters and everything than the hospital births. And then again, you know, to the traumatic birth or whatever. But in the hospital setting, you know, once that baby's born, they very often take the baby to do the weighing and measuring and everything before they've even put baby on mom. And I think as doulas, we are trying to encourage them to leave baby on mom's chest for a long time before. But you know, hospitals have so many protocols, and unfortunately, the midwives and nurses that are in the hospital setting that have come, you know, through their career has been employed in a hospital. There's no independent, you know, they haven't gone out on their own. They don't know how incredible that moment is of just leaving the baby and leaving that cord. And so, how do we get it out there to moms, especially, to have the strength to say, I don't want you to weigh the baby, measure the baby, anything. I want baby on my chest for as long as possible.
So I get my mums and my dads to first of all talk about who they are. I am this person. And if you talk about how you introduce yourself, in days gone by, we would have introduced ourselves as I am Sharon, daughter of Kate, granddaughter of Helen, mother to Catherine. And so it gives us roots and it gives us an identity. And if then a couple is talking about who are they, how did they come together? Why is it important for them to birth in this way? Are they just crossing their fingers and hoping somebody's going to tell them what to do on the day of the birth? Or have they been reading books? Read a history of birth or immaculate deception or misconceptions or Mama Bamba. All of these books, Ina May Gaskin, give women a good idea as to what is possible. Because if a woman were to ask that midwife who's desperate to weigh the child, the baby's going to weigh the same in half an hour. The baby's going to weigh the same tomorrow. And sometimes if I've got a baby who's born with special needs, then we'll weigh the baby tomorrow because that bonding is too important to have it interrupted for measurement and weight. It's not going to make that much difference. And so if you're writing your birth plan, then your birth plan is when things are not going according to your imaginings. That means that things are going south. If there are complications, if, like Danielle was saying last week, if my waters break and I am not contracting, what would I like to have happen? What are my options? What can I ask for? Why would I want to ask for those things? What are the implications of the decisions that I am making as this child's parent? And so a birth plan is, what can I discuss with my obstetrician? Because he's going to be the guy who, or she is going to be the person who is going to come to manage complications. My midwife is going to be there for everything that is going well. So she will discuss her birth vision with me. How do you see it? If you see yourself laboring at 3 o'clock in the morning, if you go into labor at 3 o'clock in the afternoon, if you've got other children to pick up from school, or you've got somebody to pick up from a birthday party, or your husband's away somewhere, what would the plan be? How are you going to get to the maternity unit? Are you going to get up at 3 o'clock in the morning and have a bath, lie in your bath, and then bake your baby's birthday cake? You know, how are you going to distract yourself? What music are you going to listen to? What candles are you going to burn? What smells do you want to smell? Because either the room smells like a hospital, or the room smells like something that you brought with you, which is so much better. And so my mums then, if they're having a baby in a birthing unit, are having a home birth away from home. And so they bring their home with them. People laugh at how much luggage we bring, but we bring the home. We bring towels, we bring everything. So we don't have to rely on, if you go in on a Friday, you know that all the laundry's gone off to the washing in Pretoria, and nobody has a towel in the place. So we bring all our own food, because she's going to be carbo loading every 2 hours. So we bring everything with us, and that's her birth vision. And then her birth plan is, what can I ask of my obstetrician? What can I ask of the anaesthetist? How do I manage drugs? What sort of experience have I had of a general anesthetic or a local anesthetic before? And particularly mums who've done a raw diet, of course, their bodies are totally cleansed. And so even if you're going to take a paracetamol, it's gonna wipe you out. And so if you're going to have morphine in your spinal anesthetic, then that can have a dramatic effect on your sleepiness, on your bonding, on your memory, with your experience. And so yeah, that's how we get mums to manage their choices. So at 36 weeks, when she has her last appointment with her obstetrician, she takes her birth plan in then with her. I would like to have my baby with me all the time, before I leave the theater. Perhaps then you can weigh the baby. But again, if you are going to theater and you have your independent midwife with you, then she's managing the coordination of when does the baby need to be weighed. We still want to manage a complication in a way that a baby's in good condition, so that when the baby is being born, even for an emergency cesarean section for fetal distress, we want the baby to be in the best possible health that we can manage, so that the baby can come skin to skin onto the mother's chest on the operating table, and even go to the breast then first, um, and then be weighed before we leave the theatre, or be weighed once we get to the postnatal room. That's not really essential. It's just information that has to be filled in boxes, and really, we could just relax a little bit about it. But we would never want to tell any medical staff that. Please just
So
relax.
Sharon, I think the one of the points that Lisa is trying to make is that that in a hospital setting where we don't have our independent midwife, with us, where we've had our journey with our gynae, and now we're in this setting where things are where we don't feel as in control of what is happening, as that we don't want things to just happen to us or our baby. that we want to know, okay, where are you taking my baby? Why are you taking my baby there? Um, you know, is it possible that you explain to me why you are giving me this pethidine before you give it to me and not just
But you
give it to
see,
me?
no, because in my book, it's too late then to ask those questions. You have to ask those questions. You have to educate yourself
Yes.
beforehand. You have to know. You have to go into the hospital and ask them, what is the procedure? When a baby is born in your labor ward, what is the procedure? And if you are told, well, the baby's taken and rubbed down and resuscitated and vitamin K is given and labels are put on and wrapped up, and then you get the baby, then you're going to have to add that into your birth plan to say, well, I don't want that to happen. And either, therefore, if I am educating myself, I know I'm not going to give birth in that place. I'm going to shop around. So consider, because, when you talk about your experience, we have been fighting for these things for at least 35 years. I was giving birth many, many years ago, and I had to contend with, as a young midwife, the Greenham Common women, who were a very scary bunch. And they were quite militant. They were in the UK and they were trying to protest against the American weapons of mass destruction that they had brought to Greenham Common. And so they were very pushy. And they educated themselves about birth. If you consider, it used to be you went into a labor ward and you were stripped of your clothes and you were given a hospital gown. That is about control. If you have your identity taken from you, it's so that we can control you. You're now wearing a uniform that will bow down and do and follow orders. That is the purpose of a hospital gown. So we had to fight for wearing our own clothes. Now, today, you don't have to even think about that. Of course, you're going to wear your own clothes. Why would you wear anything else? And to be humiliated next with having your bum exposed out the back of one of these hospital gowns, and the toilet's always down the end of the corridor, and then they give you an enema. So we don't do enemas anymore, as far as I know. I don't think hospitals do that anymore. So an enema was 500 mils of water that went up your bum, so that you can empty your bowel, because that's more hygienic. Think of what we learned about COVID. And then, of course, you are going to lose this water out your bum, so you've got to trot down the corridor with this hospital gown on and try and get to the loo in time. Then they would do pubic shaves and shave your pubic hair. And then they would make you starve. And if you're in labor for 18 hours or 24 hours, you're getting ice chips, young lady, and you're getting nothing to eat for that duration. How can we expect the body to work? So the most frustrating thing about dealing with the medical model of childbirth is that we have all the research. Scientific research teaches us women should eat in labor. Women should not have their pubic hair shaved. Women should not have an enema. Women should be upright and mobile. Women should squat in order to open a pelvis. Babies should be born in an anterior direction and not a posterior dorsal position. Episiotomies should be avoided because they're very painful for women, and sex afterwards can be miserable for many, 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 many years to come, and sometimes forever. So we need to think about all the implications of the things that we do to women. And if we're going to scientifically explore that, it's all been done. And yet, for convenience, we put it all aside and decide, but it's much quicker if we do this. We're going to induce, we're going to augment, we're going to get artificial oxytocin up, we're going to control these contractions. And then you're going to lie on your back because I want to attach you to this machine and I'm going to put you on it permanently. And the reason why you were monitored permanently for hour after hour in labor was because we reduced the staff numbers to such drastic levels that if you have two midwives on a labor ward and you've got all the CTG machines on and the volume turned up, then they can listen and hear a baby in distress rather than sit at the side of a woman's bed and encourage her to change position or eat this or drink that or go for a walk or walk in the park. And so I hope that I am answering your question there, Danielle. When if we're going to educate women, we have to educate them in school. We have to educate them at university. We have to go into their places of work and talk to them about their choices. And we have to talk to the labor ward staff about what is paramount. Are we here to offer a service to women, or are we here to control a process? And what is better? What is the best outcome? And what gives a woman most satisfaction when she's birthing her own baby? She's not having her baby delivered to her like the blooming stalk would. She is giving birth to a child. She's at her most glorious, most magnificent moment in her whole life. And we reduce it to as what if, so what?
No, because even today I was at a birth this morning in a hospital, and I turned off the main lights and she played her music and we were just swaying and doing it. And the nurse came in and she said, "Oh my goodness, is the electricity out?" So I said, "No, we've just turned it on." So she gets, "Yeah, seriously." And so I said, "No, we turned it off so we could just relax and open that pelvis and. And she said, "No, man, we need the big lights on. Doctors and nurses can't see with this low lighting." And the mom actually said to her, "No, please leave them off." So I was very happy with that. But again, it was just these.
Did they listen to the mum?
Yeah, they did listen to the mom. So it was fine. We kept the lights off. But again, it's that hospital procedures. You've got hours. This is how long you can have a laboring mom before we rush off to theatre. This is how everything has to be done. Lights have to be on. Loud machines, beep, 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 do, 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 all these things going on. And the moms don't get time to relax into that moment. And so, again, this is when doulas come in because we definitely help with that. And I think on some small part, we are definitely shifting nurses, perhaps, to understand that there is another way, and that having a calm birth and that breathing through labor and swaying and being upright and walking and everything actually makes their job easier because we're having an easier labor. And the moms are less frustrated and they're less moany, and it actually, we can make it a far nicer place to birth. So I think looking at home births and like you're doing and home birthing unit birth, it's the way everything should be, but we're not getting that yet. We're not there in the hospitals yet. And so then
women are not complaining enough, though, are they? Women
but they don't know any different, Sharon.
Why don't they know? Why don't they know? Why?
Because what I found is that a lot of corporate moms, so moms, they're coming out of the corporate world. They've never been exposed to all of this. We in the seats where this is our passion, this is what we love. And so these moms are coming in not knowing. So now they're pregnant and they start doing the research and everything. But now all their peer group has had babies in hospitals and this is what it was. So they all speak about, well, this is what's going to happen and the doctor's going to check you then, and then, we're going to go from there. And so it really is about education in the antenatal classes and podcasts like this. We need to get it out there that these moms have a choice. And I think this is what this podcast is about.
Part of the choice is that, of course, mums have the right to choose all those bells and whistles and alarms. And there are those mums who want to have all of that and are grateful to have.
And they want someone to take control.
There's also those mums who like to frighten their peers into reducing their own guilt because they didn't do any research and the doctor did come and check every 15 minutes or every whatever, and this is what happened, and then the waters were broken, and then they did have the drama, and then they rushed off to theatre. And so I want you to have that same trauma because it happened to me and it should happen to you. And so women don't educate themselves well at all. If we're going to get our information from our peers, or if we're only going to get our information from the Google machine, then I think everybody now in the modern world knows that the Google machine doesn't always tell you the truth. And unless the thing that you're reading has a bibliography at the end and references, then you need to look deeper, and maybe not just the first article that comes up, but perhaps read a book. And if you're thinking about our message today has been that not everybody has an independent midwife. Well, in South Africa, you have more choice in South Africa regarding childbirth than any other country in the world. And so we have to ask ourselves, why doesn't every woman have an independent midwife? Because, of course, the medical aid doesn't encourage her do that, and they control her choices when it comes to childbirth. And so why don't women complain about that? Why don't they insist that the medical aid pay for the care that they deserve to have? Because the midwifery model of childbirth has far few complications, has a much better outcome and far more satisfaction for mothers and fathers and babies than the medical model of care for childbirth. So medical aid should be promoting it and supporting it and paying properly for it, and not encouraging women to have unnecessary cesarean sections that are costing everybody a fortune.
No, I hear you. We're all on the same team here. So maybe today's podcast is just about encouraging moms to stand up, educate yourself, get to know what is out there. And that midwives definitely
allow
make for a better
your
birth.
birth to happen to you, and then at the end you're like, okay, what the heck just happened?
Exactly. Exactly.
Where you're informed, okay, yes, I have chosen to birth at a hospital, but for this and this reason.
Come to the end of the hour. Is there any last takeaway that you want to add in words of encouragement for moms? Sharon?
Me? Oh, well, yes, everything we've just said. Go and educate yourself. Find out. Don't just find out when you're in labor. Oh, and then they did this, and then they did that, and then I don't know why that happened. That's even your grandmothers didn't birth like this. You're educated women.
And
Danielle?
my message to all moms is, Lisa and I were just drooling after Sharon's magnificent explanation of labor and birth last week. And, Lisa and I did our doula course through Mama Bamba, and one of our set workbooks is called Mama Bamba, the beauty and pleasure of natural childbirth. And people have said, yeah, pleasure of natural childbirth, yeah, right. But it really, really can be. It can be that euphoric experience that Sharon described. It really can. And, and that's why the three of us do what we do, because we really want to give that experience to women and empower women to be able to have those beautiful, amazing, sublime birth experiences.
Love it. Love it, and that's what we're here for. And whoever hears this podcast or watches this podcast is meant to watch it and hopefully just give that encouragement to have that power of I'm going to make this the best birth possible. Whether I'm in a hospital or with the midwife or whatever, I'm going to educate myself, and I think it's important. And I thank you, ladies. It was another wonderful, heated conversation with lots of tidbits in there for moms to take away. And we will see you next week. And we're going to talk about the doula in the room and what do doulas bring to a birth. And then we'll go on to breastfeeding the week after that. So stay tuned and get all our notifications, subscribe and like, and you can go on the journey with us. Thank you so much, ladies, and we'll see you next week.
Bye.
Thank you. Bye.
Bye.